Congratulations on a 50th meeting, Frank, and thank you for the invitation. This is a compendium of multiple societies who endorse this, and it's available on multiple websites. I don't have any disclosures other than to say that many of these slides are available on the Circulation and JACC full slide decks of 221 slides for your use. There are 10 take-home messages from the document, and I'm not going to go through all of them, but really to point out the fact that the notion of multidisciplinary aortic teams, this introduction of thresholds based upon gene-specific mutations, and then, of course, the increasing role for thoracic endovascular repair of type B dissections is emphasized in the document generally. The multidisciplinary aortic team is a big team, and it's important that we all recognize that there are many people who contribute to the care of patients with aortic disease. Vascular surgeons, cardiac surgeons, cardiologists, and, of course, imaging is critical. This is percolated into the document, and it's based upon studies that have demonstrated that if a university or hospital does more than 30 to 40 aortic procedures per year, they have better results, and that's something I think we should all aim for and consider. There's also a really good section on shared decision-making about management with specific thresholds for pregnancy and aortic dissection, which is always a very difficult conversation to have. Sorry, we're jumping around there, sorry about that. The next one is about descending thoracic aortic dissection and descending thoracic aortic aneurysms. And you can see that the thresholds are starting to change based upon sort of an assessment of the patient risk overall. And there are high-risk fixtures that are identified in all of these areas. When we talk about thoracoabdominal aneurysms, I think the general teaching for this in the document is pretty straightforward. Those who have rupture are generally going straight to the operating room unless you have available devices. Again, in the elective setting, we see a similar pattern where we see, again, open repair, particularly for those with connective tissue disorder, and then if you have access to devices, to consider that. There are features associated with rapid growth that are also called out. And I think it's notable that the controversy about complex endovascular repair for thoracoabdominal aneurysms has not been reconciled, as the data really isn't there. So in the European guidelines, that's a 2A on the far right. For us, it's a 2B. Again, in the US, we have to rely upon what's FDA-approved devices. This is how it looks in the actual text. And again, you can see the description at the very bottom about a 2B recommendation for use of complex stents in patients who have these thoracoabdominal aneurysms. For the abdominal aorta, there's a couple things that have been crystallized. One, for ruptured aortic aneurysm, we see increasing guidance about local anesthesia for patients with rupture, as well as the notion of permissive hypotension. We know that generally from our center, we've appreciated that from Ben Starnes' work out of UW, and holding the pressure down in the 70s, particularly if the patient is mentating well, is now well described within the guidelines. From patients with unruptured aortic aneurysms, again, mostly about symptomatic, mostly driven off of the size thresholds that are published by the SVS years ago in 2018. For type A aortic dissection, and I don't want to totally recap what Dr. Safi already spoke about, and there's a number of recommendations about how the aortic root as well as the aortic valve are managed, and certainly in the multidisciplinary aortic team, considering a valve-sparing root resection in the middle of a type A dissection is a tough bill to hoe, but it's now in the guidelines. But most importantly, the notion that the open distal aortic anastomosis is key in this. For acute type B dissection, uncomplicated, again, pursuing medical therapy, endovascular management can be considered. For complicated dissections, I think it generally follows a pretty solid rule for complicated dissections to pursue intervention, and endovascular is a way to go for most of those situations also. There's a nice, I'm sorry, this is a double there. For malperfusion options, you can see here again an increasing role for endovascular therapy, a variety of different ways to approach it, including lower extremity ischemia and target vessel stenting. This sort of largely follows the same rules for type B aortic dissection, where again you have the increasing role for thoracic endovascular repair in general. And for those who do a lot of vascular trauma, they may have noticed in the original guidelines in 2022 that there was a class 3 recommendation over REBOA. But this is a living, breathing document, and I look forward to sort of revising some of those things based upon this excellent paper describing an improvement in REBOA for match pairs in this very large series published actually the same month in 2022. And this is just some acknowledgments for those who contributed to making these slides. Thank you very much.